Now let's do Neuro Part 2. So with Alzheimer's disease, are there any cures available for our patients? Unfortunately not. We have treatments that can aid these patients, but nothing will truly cure them of their Alzheimer's. Any medications that we are going to be prescribing for Alzheimer's is just hoping to slow down the progression of that overall loss of cognitive function. It is a very, very depressing disease. And remember, with Alzheimer's, we have the 3 A's, and that is going to be apraxia, agnosia, and aphasia. Something as simple as knowing these terms can easily pop up on your exam. And so definitely take time to refresh on each of these if you're having trouble remembering. And then extra question here, what is a quick assessment tool that we can use that assess cognitive decline as well as possible dementia? That is going to be the mini mental status exam, also known as the MMSE. So if you're having trouble remembering the order of the cranial nerves, which are going to be very important for your exam, and you will see again, then you can use this quick little mnemonic, O, to touch and feel a great vein, ah, heaven. So you just use the first letter of each of these words to remember which cranial nerve and where it falls. So we've got the first cranial nerve, and that is the olfactory nerve, and that starts with O, right? So just like the first O in the mnemonic, and you just kind of work your way down that way. And there are also other quick little mnemonics, like you have one nose, so the first cranial nerve is olfactory. You have 2 eyes, so the second cranial nerve is the optic. And something else to point out about cranial nerves too is that the exam only lists them by number, and more specifically the Roman numeral. So they're not going to give you the actual name. So make sure you know them by the name and the number. The same trick can work if you're having trouble remembering which cranial nerves are sensory or motor or both in nature. You can use the saying, some say marry money, but my brother says big brains matter more, as mnemonic. And so here, if we're looking at the first cranial nerve, this word starts with S, so we know that it's a sensory nerve. Versus down here, the fifth word, the fifth cranial nerve, that word starts with B, so we know that it's both sensory and motor in function. A cranial nerve that we definitely want to be aware of is that trigeminal nerve, also known as cranial nerve number 5. What happens to a patient when they have an issue with their trigeminal nerve? Well, we're thinking trigeminal neuralgia, and so they're going to have a severe stabbing pain in their face. And how do we treat trigeminal neuralgia? Well, trigeminal neuralgia and Tegretol both start with a T, which is one way to remember this treatment. You also have a couple of other options too, but Tegretol is the biggest one. We will worry that if we can't get this under control, what may happen to the patient? Remember, this is a severe stabbing pain. They may actually be at an increased suicide risk. Another cranial nerve related condition that we have touched on a bit in the eye section is Bell's palsy. Which cranial nerve is affected by Bell's palsy? That is going to be the facial nerve, which is cranial nerve number 7. And what did we say in the eye section about Bell's palsy? What kind of treatment are we going to do? Well, we want to use an eye lubricant to prevent them from getting a corneal abrasion. Now let's talk about one of the most important cranial nerves to understand for your exam, cranial nerve 8, the acoustic nerve. Now we have 2 ways that we are going to assess cranial nerve 8, and that's going to be the Rennie and the Weber. So let's dive in a little bit further. So with the Rennie, this one is really the easier one to remember, in my opinion. And so a trick that you can use to remember is that the Rennie is under the penny. So we are going to place our tuning fork under that penny, which is on the mastoid bone initially. And so in a normal Rennie, air conduction is 2 times longer than bone conduction because A comes before B. So it's alphabetical order for that normal finding. So again, for a normal Rennie, air conduction is 2 times longer than bone conduction. For an abnormal result on this test, it just flip-flops. So bone conduction will be longer than air conduction. It's really that simple. So don't make it complicated. Learn this one first, and then you can move on to learning the Weber, which is a little bit more complex. So take a good look and see how this picture is shifted now, because the tuning fork is not under the penny anymore, it's on top of the head. And for this section, please do not hesitate to listen to it a couple of times in a row, because you might not fully absorb it the first time, but you will if you listen to this a couple of times. So with the Weber test, you have 3 results you might see. It will lateralize to the good ear, it will lateralize to the bad ear, or there will be no lateralization. And lateralize is just a fancy word for the sound that will be heard more in that ear. And so if it's sensory neural hearing loss, the sound from the Weber test is going to lateralize to the patient's good ear. For example, the patient is having hearing complaints in their left ear, so the right ear is the good ear. If something sensory neural is going on, then the sound just lateralizes to the side without an issue. If it's conductive hearing loss, the sound of the Weber test is going to lateralize to the bad ear. This means that they will hear that noise louder in the ear that is currently having the issue. So if their left ear is bothering them, then that sound will also lateralize to the left ear during the Weber test. But we also need to remember normal finding here too. And so a normal finding is that there is no lateralization. So it doesn't lateralize to one ear or the other, which just simply means that we can hear it equally on both sides in both ears. So then the question becomes, how do we remember what is conductive hearing loss and what is sensory neural hearing loss? Well, conductive hearing loss, it is an issue that we can see. So we can see something like a cholesteatoma or a cerumen impaction. It is something we can physically see. So for example, if our patient comes in and they have a cerumen impaction in their left ear and we do the Weber test, that means that the Weber test is going to lateralize to that bad ear, which is the left ear that they're having issues with. Meanwhile, with sensory neural hearing loss, there are issues that we cannot see. So things we cannot see include things like Meniere's disease, age, medication, things we cannot physically see. Now, what about if our patient has something called otosclerosis? Well, first of all, what is otosclerosis? Otosclerosis is when those bones in the middle ear become stuck in place and they don't want to vibrate anymore. Is that an issue we can see? Yes, because it's in the middle ear. And therefore, we know otosclerosis in particular is a conductive hearing loss issue. And so just kind of work your way through a couple of these questions, and then once you've got this, you've got this. So to tie it all together and do a little practice, we have a new graduate nurse practitioner that has a patient with a hearing complaint. The patient states that they have had decreased hearing on the right side for the last month that is continuing to get worse. The nurse practitioner completes both the Rennie and the Weber test, and if the patient has Meniere's disease, what would be the expected finding on the Weber test? Air conduction is 2 times longer than bone conduction. Bone conduction is 2 times longer than air conduction. The tuning fork lateralizes to the right ear, or the tuning fork lateralizes to the left ear. So with this question, we got a lot of fluff in there that was irrelevant. And what we really need to focus on is in the last line of the question, which is, if a patient has Meniere's disease, what is the expected finding on the Weber test? What type of issue is Meniere's disease? Is it something we can visualize on physical exam? No, we can't, which means it's what type of hearing issue? sensory neural. And where does that sound lateralized with sensory neural hearing loss? To the good ear. So in this question, the right ear was the one giving them the issue. So their good ear is the left ear, which makes answer 4 here the correct answer. Like we talked about earlier, and I've said a couple times, if you need to watch this portion again to make sure you have it down, absolutely do so, because these are easy points on your exam. And then lastly here in neuro, let's talk about Meniere's disease, because we just talked about it in the previous question. What does our patient with Meniere's disease present with typically? Things like vertigo, tinnitus, ear pressure. And it can actually be really common to see some nystagmus as well. And so our biggest concern in a Meniere's disease patient is what? A potential permanent hearing loss. Definitely something you want to write down and remember, a potential permanent hearing loss. And that's it for neurology.